Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, friend. Welcome back to this week's episode of the Healing Pain Podcast. I am your host, Dr. Joe Tatta. It's great to be here with you again. On this week's episode, we're discussing the importance of integrating the lived experience of pain into pain care, pain research, and even pain education. My guest this week is Joletta Belton. Joletta is a writer, a nature lover, and an advocate for the integration of one's lived experience into pain research and treatment. Her advocacy work around this topic started after years of living with ongoing chronic pain, struggling to find answers or not finding answers, and going through a number of treatments which actually failed to provide effective pain recovery. When her struggle with chronic pain forced her to medically retire from her career as a firefighter paramedic, she returned back to school to study human movement with an emphasis on exercise psychology and a focus on pain science. This gave her a better understanding of what pain was and how important the lived experience of pain is in someone's recovery. She's also a patient partner in pain research, and she guides the development of different education programs with research teams around the world. On today's episode, we'll, of course, discuss the lived experience of pain. We're going to approach it from a couple different angles. We'll approach it from the clinical angle. We'll approach it from a research angle. And then finally, we'll approach it from a more social justice and disability justice angle to kind of bring in all the different layers on why this is important for us to raise awareness around. Okay, I really enjoyed speaking with Joletta on this episode. I could have continued to speak with her probably for about 3 hours because I think this is a super important topic. Make sure you share this with your friends and colleagues on social media. And without further ado, let's begin and let's meet Joletta Belton. Hi there, Joletta. Welcome to this week's episode of the Healing Pain Podcast. It's great to have you here.
It's so great to be here. Thank you, Joe.
I've been looking forward to speaking to you for some time, and I've followed a lot of the work that you've done in the world of pain care, specifically through the lived experience. You have really started to take this concept of the lived experience and really put it to play in lots of different areas in helping clinicians identify with it in clinical practice and helping researchers bring the lived experience more toward a research focus, and obviously bringing in people with pain and with the lived experience of pain into all of our systems, really, where we care and identify and treat pain. I think, the lived experience, the word lived experience is kind of thrown around loosely now, not just in the world of pain, but I think in the world of mental health and physical health and disability justice and social justice and health justice. What's your definition, or how do you look at the lived experience of pain? How do you define that?
Yeah, that's such a great question. And I do think there's overlap through all of those different areas that you just mentioned. But for me, I don't know if I have a definition per se as just how I think of it or conceptualize it in my own work. And for me, lived experience is just another way of knowing pain. So living with pain is another way of knowing what pain is like, knowing what matters during a pain experience, knowing what seeking care for pain looks like, knowing how treatments work or don't work. It's this lived way of knowing the work of pain, if that makes sense. Like, how do we engage with health systems when we have pain? How do we deal with our own symptoms and emotions and thoughts and behaviors around pain? How do we conceptualize pain ourselves? How do we understand the pain that we are experiencing? What do we think are contributors to it? What do we think, is the cause of it? What do we think might help? All of these different ways of knowing this big, huge, complex phenomena of pain. And for me, it's complementary knowledge to clinical knowledge into the scientific research. It's a way of expanding our understanding or deepening our understanding of what pain is, because we can break down the person into all of their biological systems or behaviors or all of these different things and study those in depth through the science, which is really valuable. But we also need to be able to put all of that back together into a whole person that's experiencing pain and understand how all of those things are actually relevant to that experience of pain and how they play out in an experience of pain. So for me, the lived experience is just being a person living with pain and what I have learned from that experience, and how what I have learned, those insights and that perspective, can contribute to the field of pain overall and can complement the research or clinical expertise. And then also taking that to me, not just my experience, but many experiences, because my experience is mine alone. And it's going to be different than someone else's experience. It might have had the same type of injury, the same type of surgery, all of that. Their experience is going to be different because of, all of these other factors that contribute to just our experiences as a human being, but our pain experience and our healthcare seeking and treatment experiences as well. So a very long and complicated answer to a simple question.
Well, I think we're going to get a little bit longer as we go here. But I think a good point to land on for a minute in your wonderful explanation there is that there's not just one lived experience, right? And you mentioned one's lived experience is going to be based on their life and their experiences, both their past experiences, their current experiences, and many, many other, as we say in pain care, multidimensional aspects of that experience. But it's interesting though, because when you look at a lot of the pain researchers, and to some extent, researchers mostly, but to a lesser extent, clinicians focus in, I would say, a handful of different types of experiences. When I think about it, it's always pain catastrophizing comes up as part of someone's lived experience. Fear of movement, or what's called fear avoidance, comes up. Kinesiophobia, similar concept, comes up. Depression, anxiety comes up. And over the course of reading all of that research, I think it's wonderful that we've identified risk factors and we have some evidence to prove those constructs. But do you look at this point, having studied the lived experience and had your own lived experience, do you look at that and feel like we have really reduced this to just a couple of concepts that doesn't even start to really explore or describe what someone's going through?
Yeah, very much so. And I also think that those concepts are developed through a very particular lens, and probably a pretty biased lens, just based on how we learn about other people and we learn about pain within the educational systems that we're in, and then just societally what we learn about things. So everything has a very negative connotation whenever we think about pain or we think about psychological factors or behavioral factors. Everything is very negative. Mm-hmm. And I think that skews then also our perception of people living with pain, and it makes everything seem challenging and like it needs to be overcome. And that's often placed on that individual. They need to start thinking differently, behaving differently, all of these things in order to fix their pain, which some of that is probably true, but we could also probably learn from them some of the things that they're doing really well and capitalize on those things a bit more too. Focus more of our research on what is working for people living with pain in those experiences that might just tint the lens. Can't think of the right phrasing for it, but it might change that lens just enough to change our research focus just enough that will change the outcomes for people even a little bit more and have better outcomes than we do now, because the experience of pain is so broad and so wide. And when you look at the qualitative literature of people living with pain, there are very distinct themes that come out, and it's not fear avoidance, it's not catastrophizing, it's not these things. It's more their interactions with the health system, it's how they are treated by health professionals, it's being doubted or feeling like their pain is invalidated. It's not having support. It's more of these social factors that are beyond their control, mm-hmm. and that are often systems or structure driven. And we don't focus on that stuff enough. Maybe if we started focusing on more of those system and structural issues, there would be less fear avoidance. There would be less catastrophizing. There would be less of those kind of negative aspects of pain, because they are better supported. They better understand their pain. They're able to make sense of their pain. They're working within compassionate systems that aren't just compassionate towards them, but also towards the health professionals working within them too. Because like we said, pain is complex and everyone's experiences are going to be different. But we have very individualistic and narrowly focused ways of approaching it that I think do a disservice to both people living with pain and to people working within those systems too.
I appreciate that on a lot of different levels, because, I think, those of us who are living in these pain science, pain education vacuums, we have now absorbed the message that pain has both a physical and an emotional component to it. It's a lot of focus, as you mentioned, on psychological factors, which are important. They're part of a biopsychosocial approach. But two things come up for me as you're talking. You're really saying, yes, we've studied those things. There's research evidence to support them and identify them, and we should take those risk factors into consideration. But what you're really saying is instead of taking a biopsychosocial approach or even a psychosocial approach, you're really saying that when lived experience comes in, we have to take a socio-psychobiological approach potentially first, because the social factors are weighing heavily, and we may not necessarily have ways to measure that. The other thing which I really like is a lot of what you're doing is you're starting to kind of, tease apart these concepts and say they're important, but let's not place them squarely in the domain of psychopathology, so to speak. So a lot of those psychological factors like catastrophizing came from it was a construct that was pulled from depression research, right? Basic cognitive behavioral therapy, where they're looking at maladaptive thoughts, how it leads to maladaptive behaviors. And now we're, applying that, or we're mapping that to people with chronic pain. But I've never felt comfortable with looking at chronic pain as a negative psychopathology. I don't think it has any place in the DSM. I think, yes, we need to be able to code things so people can get insurance and things like that. But as you mentioned, we're looking at it through this lens. And I wonder if bringing more of the lived experience in takes it out of the psychological lens and puts it more into the social support lens.
Yeah, and I really like what you said there about how when we do think about the psychology, it is psychopathological. When we look at the bio and the systems and that kind of stuff, everything is this very pathological based focus. And I don't know what would happen if, instead of looking at everything as being pathological or maladaptive, especially when it comes to things like thoughts and behaviors and actions and responses, if we just took a different approach to looking at these things. Like maybe someone's catastrophizing or fear avoidance is incredibly protective and helpful for that person based on the context that they're in, their experiences in life leading up until that point. If they've had trauma experiences, if they've had really negative experiences in the healthcare system, like these things are not maladaptive for a lot of people. They're actually adaptive. They're what helping them to survive.
Mm-hmm.
Could that change over time? Yeah, but that doesn't mean that it's maladaptive in this moment. And I think that we put ourselves in a box when we always characterize things that we view as not helpful, when we don't really understand what that person's context and experiences and environment and all of that might be really adaptive for that person. They might not be here without those behaviors or thoughts or actions. I think that by bringing in more of that lived experience, and it doesn't even just have to be, patients or people living with pain who are not health professionals' lived experience. A lot of health professionals, a lot of researchers live with pain themselves too, but they don't bring their personal experiences to their work because they've been told they can't. They shouldn't. That's unprofessional.
Yeah.
I think we need to break down that barrier too, because it humanizes the research when we realize it's humans that are experiencing pain. It is not an abstract concept. It's not an academic concept. It is a very real, often challenging struggle for people, especially early on, if they don't have answers for it that make sense to them. If they've been through numerous treatments that haven't worked for them, it is really freaking hard. And we need more of that humanizing of pain research and clinical approaches. And I'm a huge advocate of breaking down those barriers between like them and us, health professionals versus patients, or researchers versus clinicians. Like, let's all just get into a room together and talk like humans and figure out better ways forward. Because right now, I think it sucks for everybody. Like, we're not doing a very good job of even implementing the research that we have that's really good into science or society in meaningful ways that people can actually act on, and clinicians are often hamstrung by insurance systems or the workers' compensation system or whatever it might be, and not able to help patients in the ways that they would like to because of these structures and policies and systems are in place. And so the way that we're going about things right now, I think could benefit from all of those groups coming together and situating it, truly being patient-centered. We pay a lot of lip service to patient-centered care, but really most of our care is system-centered.
Mm-hmm.
It's health system-centered, it's insurance-centered, it's hospital-centered, whatever it might be. It is not patient-centered. So how do we move that needle to being what we aspire to be, which is truly patient-centered care? We need to put those people, those patients at the center of how we explore questions about pain, how we explore treatments about pain, how we explore policies about pain, that sort of.
That's a really good point, because when I train professionals, most of them are physical therapists, but I train other professionals too. And they say to me, well, how do I bill for this? How do I code for this? Or there is no code for this. Like, I can't find a code for this. And I kind of wish I had you 5 years ago. I think that idea of you're supposed to be providing patient-centered care, realizing that you're also working within a system that is 100% completely antiquated.
Yeah.
And in a lot of ways, just totally, like, what is maladaptive and dysfunctional is not someone's thoughts and behaviors and attitudes and beliefs. It's the system that they're embedded in.
Hallelujah. Yes.
Right? Exactly.
Yeah.
And I tell professionals, I'm like, if you're looking for this special code to treat chronic pain, it doesn't exist in physical therapy. It doesn't exist in occupational therapy. It doesn't exist in psychology. It doesn't exist in social work, and it doesn't exist in medicine. The system that you're now trying to embed these new and wonderful skills in is completely broken. So you're trying to promote health in someone and help them cope more effectively with their lived experience from a system that is fragmented and busted in lots of different places.
Yeah. And part of that system was created on that pathology model that
Yeah.
you just identify a pathology and you take it out, or you target it with some kind of medicine or surgery, and that's it. That's what medicine is. And that's not what health is. That's not what healthcare is.
Right.
But
Because
we're
the
still
pathology,
stuck in that model.
yeah, because ultimately it's still a biomedical model.
Yeah.
Even now you see, like, some places are popping up and they're saying integrative pain care and all these other things. And I'm like, it's still a biomedical model. You're trying to put a round peg in a square hole in a lot of different ways.
Yeah.
So the lived experience is for the person with pain. So they can start to understand their pain. They can start to cope with their pain, and they can start to have a different experience around their condition. And obviously we hope that leads to pain recovery, right? The lived experience is also for practitioners, so they can more fully understand what pain is. Because if I read between the lines, I think what you're saying is that empathy alone is probably not enough to be an effective practitioner when you're working with people who have a certain experience. And then if you're working in a clinic, realize, let's say you're seeing 10 patients a day, you may have 10 different pain experiences that you're now interacting with as a professional.
Yeah. And I think that there's a lot of universal things that we can kind of learn from people with lived experience of pain that is done through qualitative research, but I think it's more powerful when patients are included as partners in the research, whatever that might be. And that could be in basic science and preclinical research as well, that we learn from those perspectives throughout the research spectrum. But we can learn some things that are relatively universal when it comes to patient care. And some of them I mentioned earlier, that so many people living with pain feel invalidated or disbelieved, or that their pain is doubted, or especially I come from an experience of being in the workers' compensation system, which was such an adversarial and challenging system to be in, where you feel like your integrity as a human being is constantly being challenged, that your truthfulness is constantly being challenged, that my pain was consistently doubted by the system, which is made up of people. So we can all challenge these systems. We all work within them. When your pain is doubted like that, and you feel like you have to prove it over and over and over again, your worth as a human being is being doubted. You're having to prove your worth as a human being. And now we're coming to the PT clinic with all of this weight on our shoulders too, that we don't even know we're under sometimes. And now we're in, a new clinic with a new clinician that is seeing us for the first time without really knowing our history of interactions with the health system, which might not have been positive. So there are so many things that can be done within that encounter that can set it off kind of on the right foot. And that validation and that explicit belief in that person, that even if you do not know the way forward in that initial encounter, that's okay. But you just have to believe that person and let them know that they are believed and validated and all those things. I know a lot of people think that it's implicit in healthcare, and it's not. It is not. And I saw a lot of wonderful clinicians during my years of actively seeking care for my pain. And all of them were good people that I knew wanted to help me. But being within that system, I still felt so doubted and disbelieved because the person who was in charge of my care wasn't any of those people. You know what I mean? So I feel like there are some universal things that we can do to improve those 10 visits in a day. And that's just communication and being a human to another human, and having a more collaborative approach to care, with the caveat that not all patients want to collaborate in their care. They just want to be told what to do. And that has to be an acceptable way forward too. If we're having truly patient-centered care, we can't try to fix that want in them either. Potentially that could change over time through relationship building and communication over time and that sort of thing. But I also think that even when it comes to like implementation of some of the stuff that we've learned, like pain science education, how that's integrated into care, how exercise might be presented to someone, what an exercise program or a meditation program or whatever, strategies clinicians might want to be implementing in their practice, those strategies, those types of programs can be co-developed with members of the community that are living with pain. And they're probably going to land better with those people if they have some input into those programs overall. Because we know, as great as pain science education is, even the best numbers are like a number needed to treat of 4. That means that most people still aren't experiencing a benefit from it. So we need to do something to change what we know can work, how that can be more successful for more people in the real world. And that involves bringing the real world into those processes earlier, whether that's guideline development or treatment program development, or even earlier, the research itself.
Can we talk about the workers' compensation system for just a moment?
Oh, yeah.
Or maybe we'll just keep this recording going for the next 4 hours.
Yeah,
So
where to even begin?
Yeah, that's right. Of course, as I know, all the practitioners are listening to this and cheering you on, because you very distinctly stated that the person in charge of that whole process oftentimes is not a licensed health professional, or maybe is a health professional, but they're kind of more on the administrative side. And there's a disconnect between the person providing the care and the person making the decision about the length and the duration, the intensity of the care, so to speak. So that's the first thing that I want to thank you for. The next thing is just, and putting this into the context of lived experience, when I've worked with people in the workers' compensation system who've been injured on the job and have a claim, what I really find that system does, and I'm not really sure if it's intended to do this or if anyone's really looked into this, but since there's a change in someone's social role quite dramatically, like one day they're working, boom, the next day they're not, right? So your social role changes from being an employed, quote unquote, productive person, which is a big thing in our society, right?
Yeah.
To not being employed. There's this almost instantaneous change of someone's sense of identity.
Yeah.
And maybe you can just comment on how that change impacts their lived experience, because that's what we're talking about today.
Yeah. And I think that is such an important part of the pain experience that we don't address very much or enough. And it's interesting because we were talking earlier about how so much is like about the individual psychological experiences, and we focus on fear avoidance and pain catastrophizing and all of those things, but we don't focus on identity, which is the core of all of us, whether we live with pain or not, and how much that identity can be disrupted by a pain experience, even an acute pain experience. Like if that acute pain experience is taking you away from your profession, or if you're an athlete, whether, pro or recreational, we often identify ourselves by those things. Before my pain experience, I would have said I'm a firefighter. And to me, that encapsulated everything that I was. Like, you knew who I was when I told you I was a firefighter, and I was a lifter and a runner and all of these things that was completely disrupted by this pain experience. So now I'm like, what am I left with? Because so much of my life was my job and all of these very physical activities that I did in support of my job, but also just because I really liked doing those things too. And all of that is disrupted in pain. Cass McGregor just published a poster not too long ago, like the end of last year. It's an award-winning poster on acceptance. It's called The Ecosystem of Acceptance in Chronic Pain, something like that. All of those words are in there if you Google them. I'm sure we can put these in the link in the notes too. But in that too, that identity disruption was a part of that. I did some work with Fran Toy, a healing journey with chronic pain, which was a meta-ethnography. Cass's poster is based on a meta-ethnography as well. I can't say that word. Identity disruption was a huge part of that as well. Across the qualitative literature, this identity disruption is a part of that. And we don't address that very much. One area where I think that this is addressed better than in most places is in like elite sports. in sports psychology, bringing in sports psychology and realizing injured athletes not being a part of their team and not being able to play their sport is really challenging and difficult and distressing and life upending for them. So they're doing a better job now of supporting, athletes that are taken out of the game for whatever injury reason. I think we need to apply more of that just in the general, population too, because a lot of us identify by our professions.
Yeah, you're taken out. Well, in some way, you're taken out of the game of life.
Yeah, you're taken away from all of the things that you enjoy doing, or the groups of people that you used to hang around with, or the activities that you used to engage in on a day-to-day basis. Like, your life is so disrupted and upended, and it can be exacerbated in the workers' compensation system, which often takes a really long time. Like, in my own experience, I once went 4 months without receiving any care at all, despite daily phone calls, despite, just begging for any kind of treatment. And in so much of work comp, like, you're essentially investigated that your claim is real before providing care, which just makes whatever it is that you're experiencing that much worse. Because you're not even getting bad information when you're not seeing anybody. You're not getting any information. And then, no wonder people catastrophize. If you're just left to your own devices, you have no idea what's going on. You're not getting any support or care. Like, what else are you going to do but catastrophize?
I mean, even the word claim, you have to fill out a claim. Right. And then someone judges that claim and decides whether, your pain experience is legitimate or not. And do you legitimately deserve, or do you legitimately need services for your pain?
Yeah. And I mean, like I said before, that puts so much on your value as a human being. You're not valued as a human being. I know from my own experiences, just my self-worth plummeted being in the work comp system and experiencing that doubt, and that it was just so adversarial. Like, you feel like you're fighting. I mean, when you hear people talk about being in the work comp system, they're always fighting the system.
Yeah.
It's always a fight. It's never good. And my experience in the work comp system, I ultimately had surgery for my hip. I had reconstructive surgery on my hip, and my surgeon was absolutely fantastic, wonderful human being, always made me feel heard and believed and listened to, and like my pain was real. Even after surgery, when I was still having pain, he never once made me feel like I was to blame for it or anything. Fantastic human being. He was the one that told me just to get out of the work comp system. He's like, just get out of it. He's like, you're smart enough, you'll be able to figure out what you need to do on your own, because they will not support you. Like, everything that he thought would be helpful, they denied. And rather than me fighting it over and over and over again, he's like, I would just get out and figure it out. He's like, I know that's terrifying, but get out and figure it out on your own, because you're never going to be helped by them. And what a terrible health system for people to have to be in. I've been corrected before by health professionals saying work comp is not the health system. I'm like, oh, yes, it is. Because if you're in work comp, the only health care that you can get for that injury, in the U.S. at least, is through work comp. You cannot see your primary care physician about that injury.
Workers' comp is clearly a part of our healthcare system. Yeah. In many ways. In some ways, it's very entrenched, depending on which state or which jurisdiction you're in.
Yeah.
So
I didn't mean, I totally went off. I'm like, you got me all worked up about work comp.
That's okay.
I think that it would be really interesting to see, even just outside of the work comp system, what would happen if we focused more on those identity issues and the social role disruption and all of that with pain. Because I think that is one of the most distressing aspects of pain, is just not being who you were anymore, and not knowing who you're going to be with this pain that you, for many people, have not yet made sense of or know what to do about. I think that's crucial to so much, and not something that I think we've looked into enough.
Thanks for going on that little tangent. I just wanted to make sure we touched on the workers' comp system and the role of identity. I think it's important. Bring it back to the lived experience. And so we've talked about the lived experience through the lens of the person with pain, which I'm encouraging people now to say, instead of patients with pain or patients, they're people with pain. Yeah. Like, I think that's a really important distinction to make. Like, they're not patients, they're people with pain. I'd love to have that language used more and more.
Me too. And that removes some of that us versus them barrier too, because we're all people.
Yeah, right. And oftentimes all of us have pain or have had pain at times. We talked about the impact of lived experience on the clinician. Looking at research specifically, so for researchers, oftentimes when you bring in lived experience in the realm of research, they're qualitative studies, which are very different than quantitative research. So quantitative research, we're looking typically at numbers or how we can measure something objectively. Qualitative research, we're looking at kind of gathering a bunch of data together. Typically that data is reports from people or patients, and then seeing themes that occur, so to speak. Does the lived experience extend beyond just qualitative research? And where would you like to see more of this instituted in our evidence-based hierarchy?
Yeah, absolutely. Well, and first, I think a lot of qualitative research, even though it is getting at more of the lived experience of pain, it's usually still done to people. And qualitative research, I think, is made stronger when patient partners or people living with pain are a part of the research team too, and formulating what question is going to be asked, in doing the data collection and data analysis and developing whatever conceptual model might come of that work, and then, getting that information out into the world. I think that we need, obviously very biased, more lived experience perspectives or people living with pain on research streams across the research spectrum, though, from basic science and preclinical work to clinical work to implementation science. And people with pain are bringing not just their lived experience of pain to the table, but all of the qualities and skills and talents and other experiences, work or education or just life experiences to those collaborations as well. I am a part of the Global Alliance of Partners for Pain Advocacy through IASP, and we had a booth at the most recent World Congress on Pain. And I was so encouraged by the number of basic science researchers that came by to talk about how to better integrate people with lived experience into their own work. And those conversations, I think, are often, I shouldn't say the most interesting. I'm going to share a little bit of my background to contextualize that too. Because when they talk to people with lived experience of pain and they understand like some of our shared experiences that we have, like in one conversation, a number of us with pain also had like gut issues. Like different gut issues for all of us, but we all had gut issues. A lot of us had tinnitus, however you say that. I always say it wrong, but the ringing in your ears, which I also have. Or I've had other vestibular issues like vertigo. Like, so why are these things so common in people that have chronic pain? We're an entire group of us that are there. All of us have some of these shared experiences. So the basic scientists are going, why is that? Like, are there shared mechanisms? Like, they're starting to think at more of that reductionist biological level, but the questions that they're thinking are coming from the people with lived experience of pain. So our experiences can also play a role in what types of questions are asked at a mechanistic level, and learning from people with pain, I think, can improve research across the spectrum. Like I said at the start of this answer, people are bringing all kinds of skills and qualities to research. My history, my own personal educational history, many moon ago, I was in a neuroscience PhD program and I worked in an animal lab. So I've done basic science research in animals, and it was neuroscience. It wasn't pain, because I didn't know I was later going to have this chronic pain experience where it would have been helpful. It was in attention and memory, but I'm also bringing that experience to whatever partner group or research group that I participate in too. And other people are bringing, healthcare experiences. They might have worked in the healthcare system before their chronic pain experience or their pain experience, or they might have worked in administration or in education or communication or, media. Like, they have all of these skills that can help bring this research to life in ways that the researchers themselves might not be able to do on their own. They bring histories in engineering and statistics and mathematics and all sorts of things that can complement a research team in ways that are beyond them just bringing their pain experiences. It's just bringing that very human experience to the group and contextualizing that research through their lived experiences in a different way. So yeah, I think that patient partners or people with lived experience, now patient partners is used a lot in this work, which I also have issue with. You said they're also people, and oftentimes people who are not in active care for their pain. Like, to me, I'm only a patient when I'm in my doctor's office or at the physical therapy clinic. I'm not a patient in my day-to-day life. Like, I'm not a patient right now. So I always struggle with that term. But people with the lived experience of pain can be partners in research across the spectrum, from basic science to implementation science and everywhere in between.
So involving people with pain in the research, does it in some way recognize and resist those who are, does it recognize people who are marginalized and resist us further marginalizing people with pain? Because there are a lot of people with pain who come from marginalized groups. But I personally think overall in general that people with chronic pain are marginalized in general as a whole. Yes, we can go down and dig into, various groups, women, LGBT, new Americans or immigrants, things like that. But I wonder if this starts to bring that voice in and say, hey, come out from the margins and come to the center. And I'm interested in what you have to say, and I'm interested in what your experience is.
Yeah, I think it's really important to do that. And I don't think we're doing it well enough now. When you look at the patient partner space, it tends to be very white in very high income countries. So across the research spectrum, it's still very true, even in the patient partner space or the person with lived experience space. I think that that's changing, and it's up to us to change that, to look around the room and say who is missing and ensure that we're including more of those historically excluded voices at the table or in that research team. And we can all, raise our hands and just ask, like, why don't we have someone with pain here? Why don't we have, someone who may have had a racialized experience or experienced homophobia or transphobia or something in their care? Because that's going to impact their pain experience too. And we need to learn from those experiences. The U.S. Association for the Study of Pain just recently published a 3-part series on an anti-racism framework for pain, which I think is really important for us to start thinking about more broadly too, because we still live in a society that treats people of color, people who are Black, people who are Indigenous, people who are, of Asian descent differently than white people in a lot of healthcare systems. And people were often taught in medical school that, false things that have been proven false now about people who are not white. So I think we need to do better, both in general in research and clinical care, but even in the patient partner space or the person with lived experience space, to ensure that we're including people that have many intersectional experiences and not just white people that live with pain.
Yeah, well said. And on that note, if the listeners have not listened to already, all of you really should go back and listen to the interview with Lisa Van Hoos, who's a physical therapist who did I think, an amazing interview with me, racial embodiment and white supremacy and pain management. And a lot of people, I got some emails from people that were excited that I did the podcast episode. I got other emails from people who were very upset with me on a personal level that I'm contributing to a conversation that they don't necessarily agree with. And I'm like, look, these intersections are important to talk about because they have an impact on, yes, the pain that someone feels, but they have an impact on someone's experience because it is a lived experience. And racism or homophobia or transphobia, as you mentioned, or sexism overall does have an impact on someone's health. And obviously pain is related to your health. You mentioned before, so we talked about that whole workers' comp piece before, but there also seems to be a bit of a disability justice movement in bringing someone's lived experience into the conversation.
Yeah, I mean, so much of the environments that I'm in, we still bring up the phrase "nothing about us without us," and that's why it's important to include lived experiences as a way of knowing in all of these areas: research, clinical practice, just our general understanding of pain and education. And "nothing about us without us" comes from the disability rights movement in the 80s. So, and that's very intersectional. A lot of people with pain live with disability. A lot of people with various disabilities live with pain. So it's very much a part of this overall. When you were mentioning that lived experience across like social justice issues and disability rights issues, to me, they're all intersectional and you can't separate them out, because these issues like sexism and racism, all the isms and all the phobias have an impact on our lives, and our experiences have a huge influence on those things. And if we don't start acknowledging that, if we don't start addressing it, it's going to be really hard to fix individuals. I think we've learned that. We can't just keep putting everything on the individual, which then leads to blame and stigma when they don't get better when we think they should have. If we don't address the contexts and environments and the systems and the structures that we all operate and live and work and seek care within, it's going to continue to be a struggle to make a dent in chronic pain, because those things matter. I mean, they can't not matter. And if you've lived through, experiencing, sexist care, or, and it when you are, when you're being treated a certain way because of whatever identity you hold. And we need to start changing some of those things if we really want to help people with pain. To me, there's just no other way about it. When we were talking about the work that I do, so much of my shift in focus has been more towards this ethical bent. I see it as an ethics issue. not just a justice. I mean, justice is a part of ethics. I think we forget that too. Like bioethics has 4 main pillars and justice is one of them, but it's not one we often talk about and not often in this way. And I think that it's really important. I think that the way forward has to be through justice to improve our health systems. And those who have been historically excluded, those who have been marginalized should be prioritized. Because if we can do better for them, we'll do better for everyone.
What can a professional, whether it's a physical therapist or another licensed health professional, what can they do to start to synthesize this idea that, or to synthesize the understanding that pain is a multidimensional lived experience versus a condition, a disease, a pathology, etc.?
I think that the more they can do to learn from people with pain outside of the clinic is really important, because that's a much different context and environment. When someone is seeking your expertise and care for an immediate problem that they have, they're also in a different place, than someone who can reflect back on their experiences, that can synthesize their own perspectives and insights in a way that might be valuable for a clinician or a researcher who is working in this space. So I think the more we can learn from other people's experiences, and that can include things like reading fiction, like read some novels, because writers have been trying to tell the truth of the human experience for centuries. Like I often joke when I started to get better, which didn't mean that my pain was gone, but when I started to get better, it was some combination of pain science, Buddhist philosophy, and 19th century literature. Because even though it was written in the 19th century and most of it by a bunch of old white dudes, I saw myself on the page. Like there's human suffering. The 19th century seemed pretty miserable. There was a lot of human suffering in those novels. And so for me, it helped me to contextualize my own experience. Like I am not unique in my suffering. I'm not alone in my, or maybe I'm unique in it, but I'm not alone in my suffering. And people have been trying to figure out life, being human, pain, loss, grief, all of these things for a really long time. And I'm a part of this continuation of humanity. I'm connected to all of this humanity. And I think that's really helpful. Like if you know Lysantha Taylor at all and the narrative medicine work that she does, like she encourages people to read more literature, like fiction. And like Margaret Atwood, I follow her Substack now. She just said like, fiction is where we tell lies to get at the truth, something like that. So I think that just learning from those human experiences and taking them on board and not discounting them as a way of knowing is so valuable, because I think that's what we do. Because our experiences, lived experience, is not even in the evidence hierarchy. We are excluded from the evidence hierarchy altogether. And I think that does us all a disservice, because it's a valuable way of knowing that can help us to better understand pain and how to help people with pain or what to do about pain. So I would say take it out of the clinic, learn from people outside. I mean, people probably have friends, family members. Just friggin' talk to them. That's it. Have conversations.
Joletta, it's been great speaking with you today. I really appreciate your perspective on everything you're doing. I know you're probably one of the early people that have started to work the lived experience into pain research, but I just love how you're just straddling all these different areas. Few people can really straddle into research and talk to clinicians and obviously talk to people with health conditions, people with pain. So I appreciate the work that you're doing. If people want to follow you and learn more about your work, where can they find you?
So I'm not on social media anymore. So the best place to find me is my Substack, which is, I think it's mycupofjoe.substack.com, but I'm still My Cup of Joe, which is what my social media handle used to be. So MyCuppajo. Yeah, you can find me and I'm on LinkedIn if anybody's there.
So
but I gave up all the Facebook and the Twittering and all that kind of stuff.
Good for you. It's a good way to promote some calm in life, right? We will definitely link to My Cup of Joe, and we'll link to Joletta's LinkedIn handle as well. So you can find it on the show notes at the Integrative Pain Science Institute, or you can just Google Joletta Belton and you'll find lots of great information with regard to My Cup of Joe. If you are someone who lives with pain, or you're a practitioner who treats people with pain, please share this episode in or Facebook or Twitter, or tag me over on Instagram. That's the primary social handle where I am. You can find me at drjoetatta.com or at drjoetatta on Instagram, and I'll be sure to be social with you there and tag you back. Thanks for joining me this week, and I'll see you next week.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.